My task is to cover key concepts in health equity in 15 minutes. And I want to start by saying that recently, some staff at a county health department in Wisconsin, a different part of the state, were surveyed, and 90% of the staff agreed that health equity should be a priority. But 60% said they were not comfortable explaining social determinants of health. So I don't know about you. I know all of you are here because you care about this topic. But what I want to make sure is that we have laid the foundation for a common understanding, a common narrative, and I want you to be able to go out and spread that narrative about what drives health and about how social determinants of health work. Maybe we can figure out how, there we go. Figure out how social determinants of health work after I figure out what that work. So what determines health? So the issue is that in this country, there's a sort of a national myth about what determines health. And it's a pretty simple one, and it's basically this. If you behave yourself and you go to the doctor, you're going to be healthy. And that is this part of the county health rankings model, health behaviors and access and quality to health care. And the difficulty with this model, this myth, is it's partially right, and it's at least half wrong, as has been alluded to already. And the other half, the social determinants of health, social and economic status, and physical environment and built environment, drive at least another half of health outcomes and health inequities in this country. So I'm going to get into this a little bit more. And the reason is, again, that it's so important for all of us to be able to change that limited narrative about what drives health. And before I go too much farther, by the way, all of these slides are in your handout and more. I want to talk about health disparities and health inequities. And some people use these terms interchangeably. Some very well-respected people. A lot of people don't. I'm one of them. To me, a health disparity, this word is an objective descriptor of differences in health outcomes between groups of people. Whereas a health inequity, according to this definition by Margaret Whitehead, is a difference in health outcomes between groups of people that's patterned, systemic, unfair, unjust, and actionable. That means preventable. Right? And it's not primarily biologic in nature. So for example, men get breast cancer. Pretty rarely, but it does happen. So the difference in breast cancer rates between men and women is a health disparity, but it's not a health inequity. It's primarily biologic. But most health disparities are health inequities. So for example, in Wisconsin, there's a 10-year difference in life expectancy between all the different 72 counties in the state. 10 years. Kewaunee is the longest lived, Menominee is the shortest. That's not biologic. That's systemic, pattern, preventable. That's a health inequity. In Milwaukee, in the county, of all the zip codes, there's a 12-year difference between the longest life expectancy zip code in Milwaukee County and the shortest life expectancy. Right here in this county. And in Milwaukee City, twofold differences in rates of preterm birth and threefold differences in rates of infant mortality between blacks and whites. These are not just health disparities, they're health inequities. They're systemic, pattern, unfair, preventable, not primarily biologic. This is important, and it's also important to think about what we mean when we say health equity. So health equity is not just eliminating health disparities. Health equity is virtually the definition of public health from the Institute of Medicine. What we do as a society, collectively, to assure the conditions in which people can be healthy. So the Association of State and Territorial Health Officers, ASHO, puts it slightly differently. Health equity, a fair and just distribution of the social resources and social opportunities needed to achieve well-being. Okay, that's what we have to be shooting for when we're talking about health equity. And so now I want to talk a little bit more about how it works. How do these social and economic factors drive health outcomes and health inequities? So there's four main mechanisms. in my view. You can slice it differently if you like. But the first is that low socioeconomic status, so low income and low educational attainment, constrain people's ability to access healthcare. Access to healthcare is important, right? Transportation, lack of paid family and medical leave at work, inability to afford health insurance or deductibles, et cetera. These are important. And connected to this low socioeconomic status also affects, and it's not the only thing, affects the quality of care you receive. And I'm sad to say this from a group of people that's dedicated their careers to trying to help people, but we all have internal biases, subconscious biases. And when we see a person that we think belongs to one social group or another social group, we tend to treat them differently. And so people get different levels of quality as well. So healthcare is an important factor, but it's mediated by these social and economic factors. Secondly, there we go. Social and economic factors support or constrain people's ability to engage in healthy behaviors. If you're highly educated and you have a high income, it's much easier, for example, to live in a neighborhood that's healthy, to access healthy food. It's more affordable, it's closer to you. To be able to afford a gym membership or to live in a place where it feels safe to exercise or to let your kids go out and play. So social and economic factors support or constrain healthy behavior. So we say you should behave yourself, but we forget about how easier or harder that is for different individuals or different groups of people. The third thing is the way these social and economic factors get under people's skin and affect their physiology directly. Okay? There's a couple of ways that this happens. One is sort of obvious, the exposure to toxic physical environments. Things like lead hazards or mold hazards or particulates if you live near a freeway or an industrial complex or a brownfield, right? But over and above toxic physical environments in the outside world, there's a toxic environment that starts to happen inside as well. And that's due to toxic stress, chronic stress. Many of you have heard about this, but it's worth repeating. And it's important to distinguish between garden variety stress and toxic stress. Everybody in this room has got stress, physicians have got stress, professors have got stress, CEOs have stress. But some of us have resources to be able to manage and mitigate that stress, and other people don't. And so when you have chronic stress all the time, and you don't have the resources to mitigate that stress, then your cortisol and adrenaline levels, which go up for everyone when they have stress, don't have a chance to come back down. And when they stay high, it affects your physiology, right? So cortisol, it's a potent disruptor of glucose metabolism, so it makes people more at risk for obesity and diabetes. It's a potent suppressor of the immune system, so it makes people more at risk for cancer and other chronic illnesses. Adrenaline sends your blood pressure up, which is great if you're trying to run away from a saber-toothed tiger or save your baby from being kidnapped or something. It's very functional, except when it stays high all the time, you don't want your blood pressure high all the time. Because hypertension drives your risk for stroke and heart disease and lots of other problems. And if you're a woman, it's particularly bad because chronically elevated levels of adrenaline make the uterine muscle more irritable, so it makes you more likely to deliver a baby preterm. Preterm birth is the #1 driver of infant death. And in addition, preterm birth has a host of problems by itself for most of the babies who are born preterm and live. And that stress that affects the uterus and the uterine musculature can happen even as a young girl, even as an infant, and throughout childhood. And even if it goes away by the time you're a teenager or a young adult and you get pregnant, the effects linger. Right? So stress is getting under the skin. And I'm not even going to talk about epigenetic mechanisms because I need at least another 15 minutes. So this is an illustration of stress getting under the skin. Stress from a variety of things. Stress from discrimination, stress from lack of access to jobs and services, poor quality education, housing insecurity, lack of a sense of belonging, transportation, etc. This is getting under people's skin. And a lot of times in medicine, people will look at this and say, well, yeah, no, but that's not our thing. Like, we do healthcare. Right? But if those arrows were secondhand smoke, say, or if they were some genetic problem, say, or if they were lack of access to vaccines, say, or if they were just some virus, we would say, oh, that's our deal. That's our deal. And I'm telling you, these are viruses that get under people's skin. It's our deal. Okay? And one more thing that's a virus that gets under people's skin is racism and other forms of discrimination. The experience of racism and other forms of discrimination. It adds to those chronic stress levels and multiplies the adverse effects that people have from chronic stress. Right? You could add other things to this list too. You could add historical trauma, you could add adverse childhood experiences, but it all has this final common pathway of affecting people's health. And it's not just in the moment. It's across your lifespan and across a generation, right? And it comes down to power and privilege. So groups, individuals and groups that have higher levels of power and privilege have more protective factors and fewer risk factors. And so their health potential stays higher. It starts out higher even before they're born, compared to people with lower power and privilege on average, who have on average more risk factors and on average fewer protective factors. Health potential stays lower. And then this not only starts before you're born, continues across your lifespan, but it can get transmitted to the next generation. So power and privilege. So health inequities are reflecting the differences in lived experiences between different groups of people. Like that's really what drives the difference in infant mortality rate between blacks and whites in Milwaukee and other places. It's not genetics. It's a difference in lived experience. It's chronic stress. And so it's not mainly healthcare access and quality, although it affects that. It's not mainly health behaviors, although it affects it. It's mainly how these chronic stress pathways get under the skin and affect your physiology. But here's the thing. Power and privilege are mediated by other viruses, if you will. Societal level root causes. I want to show this diagram. You've got a full page copy of this because it's a little complicated, but it's important. I mean, this is the World Health Organization's conceptual framework on the social determinants of health. And there's three basic categories of social determinants of health that they talk about. The one in the middle, in the little box, there. Social cohesion, social capital. These are the cross-cutting determinants. Social support, community civic capacity. These are things that help mitigate these chronic stress factors and are very important for us to help to try to support and develop. And then on the right, there we go, you have what they call, a big group they call the intermediary determinants. Okay, this is what we normally think of as the social determinants of health. Material circumstances, people's living and working conditions. And these are very important. But they've got this big block, it's two blocks actually, on the left. I really apologize for this. There we go. On the left, they call it structural determinants, or the social determinants of health inequities. Okay? This is how we as a society distribute power and privilege, where some groups of people get more and some get less. Right? So we sort ourselves by gender, we sort by social class, so education, and we sort by ethnicity and race, we sort by education, which drives your occupational choices, and your occupational choices constrain your income opportunities, which constrains where you can live, etc. And then we have this whole group of policies on the left side. So macroeconomic policies, labor policies, education policies, etc., that serve to reinforce this difference of power and privilege between groups of people that drive differences in material circumstances. So when you are facing an individual in a clinical setting or a social service setting, you're thinking about their material circumstances and trying to help them because now you understand how that affects their health. But I also want you to be thinking about how you individually and in your organizations can get farther upstream to get at the structural determinants, the determinants that drive whether large groups of people in our society are more or less likely to be healthy than other large groups of people. These viruses are our concern too. So a much simpler way to think about this, there we go, is the triple aim for health equity. So three simple things. First, what I started with, expand the understanding of health. Help people to grasp that it's not just behaving yourself and going to the doctor, but it's all these other social factors that drive health. Second, strengthen community capacity. Help communities, provide support to communities so that they can help create their own healthy future. Build those social connections and those cross-cutting determinants. And third, implement health in all policies. Right, so think back to that stress slide I showed you. What David Williams from Harvard says is, transportation policy is health policy. Housing policy is health policy. Childcare policy is health policy. We need to be involved in those policy discussions as well. That's why I'm so glad we have our elected official representatives here too. And there's evidence for those policies. So there's a whole compendium at my employer, UW School of Medicine and Public Health, the What Works for Health database. Evidence-based, like for example, the earned income tax credit. The more generous a state's earned income tax credit, the lower their rates of low birth weight. Chronic stress, getting under the skin, and there's policy levers that can be used to change it. So this also is in your handout, and I'm not going to go over it. But this is a long list of policies and programs that are evidence-based, that are mapped onto the WHO framework. So you can see what helps with structural determinants, what helps with intermediary determinants, what helps with cross-cutting determinants. You can do that a little bit later. There's one more thing that's really important in your organizations, and that's the infrastructure that you need to be effective in addressing health equity. Okay? You need leadership that's focused on health equity. That's all of you guys, and it's people that you're going to take this message to when you go back to your organization. You need data systems that are focused on equity, not the garden variety ones we have now. You need a commitment to workforce development around equity. I've learned stuff every day. We all have a lot to learn on this. It has to be a commitment. And finally, the resources. There has to be money invested in this work. You can't just talk about it and be effective. Finally, in your handout, which I'm not going to go over, there are a number of specific suggestions that I'm leaving for work on the individual clinical level with people in your clinic, work at the organizational policy level. Like all of our organizations need to improve our own internal policies around equity, work at the community level, and work at the public policy level. So that's how I'm going to leave it. I want to thank all of my colleagues and collaborators, too many to list, many of whom are not on this, including my colleagues in the Building Medicine and the Walker Health Department. And I want to thank all of you, because this will take all of us. But together, we can create an environment where everyone has a fair and just opportunity, not only to get healthy and stay healthy, but to be healthy in the first place. Thank you.